So I'm going to be focused on, we're very fortunate to have two additional outstanding speakers, really kind of leaders in the field, two people that I consider mentors of mine to talk about a host of things. I'm going to focus on some of the novel targeted, quote unquote, therapy that's out there now, why we're doing that, and hopefully, and where we're going, and the promise of that. So my little bit of housekeeping. So usually say thanks to the end, but I'm going to thank people up front. And so of course we're doing this for you guys, so patients, loved ones, caregivers, family. And it wouldn't have happened without the Ann Arbor Melanoma Foundation and Valerie's Methodology of organizing this. It really wouldn't have happened from my standpoint, from our standpoint. Joe Secord has been unbelievable, basically doing about everything possible to make this happen. So a huge debt of gratitude to her. And of course Bruce and Bruce Redmond for Sinai who are here. Tim Johnson completes the University of Michigan Melanoma program, has been very supportive. And Sherry, Barb, and Donna we're helping me kind of scramble around trying to get these things, trying to get notifications out soon. So it also wouldn't have happened without their help. So when I was thinking about what to talk about overall, I was thinking about what do you think the most common question I get for when we're talking about therapy? What do you think one of the most common questions I get is? Harry, take a guess. Well, one of those is, what would you do if you were me? So I'm imagining myself being there, watching me, hoping I would fidget less and stop mumbling. But what I want to know is, initially, just some basics. What do we know about melanoma? I'm going to talk mostly about cutaneous. Cutaneous melanoma, and we're also going to talk a little bit about uveal melanoma or ocular melanoma and mucosal melanoma. I'm very much into why things happen, how does it happen. Everyone else has the same questions, and so I'm going to get into a little bit more depth of that. Hopefully, I won't lose you from there. And ultimately, what is being done to exploit that? So as our knowledge increases, how do we target that? How do we manipulate that? How do we exploit that? Ultimately, what I think everybody wants, what I would want, is to be cured. Using this information ultimately to get rid of this disease, never have it impact you, so you can do everything you wanted to do. Grow up, see your grandkids, or even have kids. We're at least very long-term control of the disease. And so we're going to start that process again from my perspective with these targeted therapies. So everyone has a story, right? If you've heard me talk, a lot of talks, you probably heard this. This is Joe. He's a tough guy, fireman, had a lesion on his chin, you can see there, years ago, had it removed, turned out to be melanoma. Didn't really make much of it, had it taken off, really didn't talk about it a lot. Years later, he started bumping into things, actually driving, running over the curb, also trying to blow it off, no big deal, kind of funny. Ultimately got it checked out, and he had multiple lesions in his brain, many of which were hemorrhagic. At that time, he was just starting to get to know his daughter again, reconnect. Had just starting to get to know his granddaughters. But it was very late. Actually, was so far advanced, really had no chance at even getting any therapy. And he died very shortly thereafter being diagnosed with melanoma. So died at the young age of 56. Joe's my father-in-law. This was in 1997. I was in medical school. And I was thinking, they couldn't do treatment, they can't do anything. You gotta be kidding. There's gotta be somebody out there, right? You go to MD Anderson, Sloan, wherever, somebody's gotta know. The reality is this was 1997, and there wasn't anything. Beyond frustrating to know that. And so I'd like to think, probably subconsciously, but I'd like to think that I spent a good bit of my professional career now, trying to be that somebody, and working with people also trying to be that somebody to make a big difference. So hopefully we have few stories, if any sad stories at all, and so we also don't have to develop foundations. We know that melanoma is not one of the most common cancers, but actually is one of the cancers that have been increasing in incidence for the last few decades, particularly in a couple of groups like young women, older white men. It's actually been estimated, though, that people today, or born today, that their lifetime risk, about 1 in 50 people who develop melanoma in their lifetime. This is increasing, the incidence is also increasing in early stage and late stage. So who gets melanoma? A personal history is probably the strongest risk factor. Dysplastic nevi, so these atypical, clinically atypical nevi, so there's something a little bit different about those. Multiple nevi, family history. So not necessarily an inherited risk, like a genetic predisposition that's passed on, at least that we can identify. But also there is known genes that have been inherited in a small number of people. Also non-melanoma skin cancer, fair skin, light eyes, light hair. These are kind of the classic ones. A blistering sunburn in childhood. These are probably more related to UV than some others, or in different ways. So we know UV is actually very important as an etiology of developing melanoma, although it's not clear the cause of all melanoma. But it is a fascinating story. And some of my own independent work is trying to look at early stage disease or prevention and trying to understand that to be able to modify that and ultimately decrease the incidence in outcomes for melanoma and improve the outcomes for melanoma. Let me talk a little bit about UV. So sunlight is made up essentially of visible light, UV, and infrared light. So those are different wavelengths of light that come to the Earth. UV is made up of essentially 3 types: UVA, UVB, and UVC. UVC is the shortest wavelength. Actually, it's blocked by the ozone. It doesn't reach Earth. So UVA is the predominant UV wavelength. It does change during different times of the year. UVB is less common. But UVB is thought, and is shown to be more of the cancer-causing, quote-unquote, UV. So the tanning industry recognized that and said, okay, we're going to do only UVA. So in the 80s, they started the tanning beds alone. Tanning beds were using UVA alone. The problem is that UV and melanoma is really, it's not clear exactly what kind of exposure, what actually happens with UV and melanoma, although it's clear, there's a clear association in some way. UVA, though, has been shown actually to induce melanoma in animals and cells. Actually, it's a longer wavelength, so it actually penetrates down a little bit farther into the skin. And I'm going to show you some pictures of the cells themselves, but they sit kind of in the basement, the bottom layer of the epidermis, which is the outer layer. So it theoretically certainly can get down or even deeper than that. And then more recently, they looked at essentially what, the tanning beds themselves, and so looked at basically all the literature that's out there, and has shown a statistically significant association with tanning bed use. So 75% increase if you use tanning beds before 35, and a 2.5-fold increased risk for women in their 20s who are regular users. And so I overheard Bernard Smith talking about legislation. But so there is a push to have more strict control of tanning bed use in minors, as this has been classified now as a class 1 carcinogen. So again, the story with UV is a little difficult. So this is just a cross-section of your skin. I'm sorry about this pointer doesn't work out here. But if you see right in the middle, that darker cell, it's the melanocyte. So melanocytes sit there. They're actually there to protect you, right? So when you're exposed to UV, it produces pigment. That pigment, the melanocytes themselves are like octopi. So they kind of spread their tentacles through the outer layer of the skin, and they essentially deliver melanin, the pigment, to protect you to other cells in the body, so you get tan. And there's a kind of intricate communication balance between the majority of the other cells, which are keratinocytes. So you've heard other types of skin cancer. Those are other cells that get damaged or cancers in there. But there again, there's this kind of intricate interplay. So when UV is either higher doses or certain types of exposure, you can have damage to the melanocyte itself. But ultimately, evolutionarily, melanocytes are there to protect you. So they're hard to kill. It's like a bodyguard, it's there to protect you, and all of a sudden it goes awry and you can't get rid of it. In addition, you have these keratinocytes, which are there really to control the growth and function of the melanocytes, and those die off. So now you have an abnormal melanocyte, less control over those, and ultimately can lead to melanocyte growth and proliferation. As well as there's some growing body of evidence that melanin itself actually can become pro-oxidant, so it can induce free radical damage. I'm sure you've heard of that. It can induce DNA damage in that way. So it's interesting because we talk about a lot of mutations. I'm going to talk about some of that here today too. You don't actually see a lot in genes and these abnormalities that are caused from UV. Experimentally, at least to my knowledge, that hasn't clearly been shown that UV, again, directly damages, that these signature mutations directly damages melanocytes. Okay, and so again, these cells kind of continue to grow and proliferate. All of the dark cells there on the right are essentially melanocytes that grow and proliferate and invade down through into the skin. So these are some things I put on the left there. This is Breslow-Depp. So you've heard of your primary melanoma. Most people who've had melanoma know the thickness of their melanoma. And that's the Breslow-Depp, literally from the top to the bottom. So again, understanding what happens, understanding some of those events, say early on. So if you've heard me talk, I like to focus on, at least where we're going in the future, really has to focus evenly on prevention, early detection, and then therapeutics. Of course, most people want to talk, for the most part, about therapeutics. But understanding UV, those early events, ultimately we can intervene and prevent melanoma from even occurring in the first place. And our dermatologists, another primary care docs even, I think there's being a huge focus on early detection as well. So finding it at a very early stage. I mean, melanomas on the skin cares, those should be the strongest push for prevention and early detection, because you can see these spots. And ultimately, again, at the end of here, which is where we're going to talk about more details about these abnormalities in these cells and trying to exploit that for improvements in outcome. Okay, at the risk of confusing you and having my daughter roll her eyes because Dad, why do you have to explain everything? But I'm going to do very basic. This is less than Bio 101. But I want to introduce it because you've heard BRAF, RAS. You hear these things. Does anyone know what those actually are or mean? So DNA, again, some of them I'm sure you know. DNA is essentially the code that makes you who you are, right? And so each individual one of those colors up there represents the DNA, and they're, again, kind of intricately connected and wound together. As you go to the right, that code itself is, again, kind of packaged up and ultimately made into chromosomes. Right? You've heard that, right? So on the upper right-hand corner is the chromosome package. And those reside in the center of the cell, which is the nucleus. There's 23 pairs of chromosomes. And all of your genetic material the vast majority of your genetic material is in there. And who you are is within that. And so the DNA, as a string of DNA together, that makes up a gene. Okay? So the gene itself, through an intricate process as well, ultimately make proteins. And proteins are what function in your body. And so when you have a carcinogen, unfortunately that middle one's supposed to be asbestos, so when you have a carcinogen like asbestos, smoking, UV, it causes damage to the code, to the DNA. So those are mutations or aberrations. It can also damage chromosomes themselves, so you have a glob of DNA that's kind of switched around. And ultimately that produces abnormal proteins. And ultimately, if those proteins acquire the ability to grow, they just continue to grow. And that's kind of the definition of cancer. And so if you see on the bottom there, that's the inside the nucleus, and a depiction of that. So the genes will make these proteins, and ultimately they're to function normally. So you may have heard some of these genes, BRAF, right, RAS, MEK. These are genes that function normally in your body, and so it's there to kind of, normal function. But again, when they become abnormal, they acquire the ability to survive and proliferate. So another depiction of that is, this is the cell cycle. So if you see over in the upper left hand corner, that's the nucleus, which is all the DNA is kind of in a mess, but it becomes formed into chromosomes. Those chromosomes, or those DNA replicate, the chromosomes split, and ultimately in the bottom right hand corner, they divide, they grow, right? That's a normal process. The problem is with cancer, one of the definitions being is uncontrolled growth. So it just continues to do that, on and on and on. And so they tried in the early treatments trying to exploit that. We didn't know a whole lot about that, but we certainly knew that these cells are dividing and growing. And so the chemotherapy that some of you may have had, maybe even still getting, is there to exploit that. So DTIC, temozolomide, carboplatin taxol. So DTIC, they bind the DNA or affect the DNA itself and don't allow the cells to replicate and spread and separate. Taxol, usually we use combinations of chemotherapy, right? Idlasine and Abraxane. And these are basically focused on different parts of this cell cycle to ultimately block that cell from growing. So it's a great concept. Two major problems with it. This is my advanced PowerPoint. Two major problems are that it attacks relatively non-specific. It is attacking cells that are growing. So you have normal cells that grow, so you can have toxicities to the normal body. The other thing is that eventually it doesn't work anymore, and you have to go on. So I didn't intentionally make that Ohio State colors, but that's what it is. Okay, so you want to be smarter about it, and this is one of the modalities is these kind of targeted therapies. And so understanding how these cells grow, understanding what happens with these abnormalities in there, we want to exploit that. So that's what we're going to do eventually. But maybe stop it, maybe just keep it from growing, maybe reverse that process, or just kill these cells off altogether. Okay, again. So this is a normal functioning of the cell. We know that in melanoma that there are some genes that are mutated. So RAS is a gene that's mutated in about 15% of patients. BRAF, which we'll talk about again in more detail later, appears to be mutated in about 50% of people. But there are other things that are abnormal in these pathways. So MEK, PI3 kinase, and this kind of confuses there, if you're approached with different therapies, you may see, hear these things. Oh, it's a PI3 kinase inhibitor, an AKT3 inhibitor. Well, you see those there. That's why, because these are growth signals or patterns that make these cells continue to grow. mTOR inhibitors. Some of you actually may have been on a trial here as well with that mTOR inhibitor. Can block the signal from outside, the signaling the cell to grow, or even block that receptor from the inside. These tyrosine kinase inhibitors. You guys have heard of that. TKIs. So there's a whole host of those things. Again, different ways of stopping that cell from growing. But with our understanding of why that grows, and ultimately, so it doesn't allow these proteins to be produced and continue to be produced and blocking the cell growth and proliferation. Okay, so I'm going to address a few of these genes. So KIT, you guys may have heard of that. So KIT is a gene that is mutated more commonly in certain types of melanoma. So even though most people think of melanoma in the skin and it's related to UV, well, you can develop a mucosal melanoma, which is either in the sinuses, in the mouth, the rectum. We don't know actually, most people say, oh, this isn't related to UV, although it's not totally clear that's the case. Actually, you can see, if you radiate a certain part of the body, you can actually see proliferation of melanocytes in other parts of the body. So again, it's an interesting thing. And also, people say they have blistering sunburns. Well, how many times do you actually have a blistering sunburn and that's where the melanoma was? So So we know that there's something about it that generates proliferation of these cells. And so, again, we think probably not melanoma, but maybe. But these mucosal melanomas, acral lentigens is the type, usually on the palms and the soles of the feet. About 15, it varies between those, but about 15% of those melanomas will have mutations in KIT. So KIT is a tyrosine receptor kinase that you see on the bottom. This is across the membrane when you show that other picture, right, about things that kind of stimulate that and ultimately send a signal to the nucleus to let these cells continue to grow. There's a number of mutations, over 24 mutations have been identified in melanoma. And it's important because we've also recognized in some studies that the people that benefit from KIT blockage, KIT inhibition, are those that actually harbor a KIT mutation. So if you don't have that, even if there are other tests where you can see the protein elevated, it's not clear that you actually respond, and probably don't respond if you don't actually have a driving mutation. So it also is important because we've also recognized that these different mutations can predict, for the most part, whether you're going to be sensitive to the current treatments. And hopefully, in the future, as we develop more treatments, we may actually be able to exploit this as well. So you may have heard of Gleevec. This was kind of the poster child, really, of targeted therapy, or imatinib. So with this identification of KIT mutations in these patients, this actually becomes a strategy where you can hopefully, and again, depending on the type of mutation, hopefully make a difference, control the growth of the disease over time. There's actually now evidence of people with certain types of leukemias with Gleevec, different type of mechanism, but now thinking potentially people living normal lives with this blockage. Not clear that you actually get rid of that, but able to control it almost completely. So another drug, statin, and there's a number of agents out there with different mechanisms, ultimately, again, same concept, to block KIT. So we are planning on participating in a trial for those types of melanoma, mucosal, acral, lentiginous melanoma with dasatinib. Again, our part will participate in those with no mutations. So, ocular melanoma is another type of melanoma, although it's vastly different than cutaneous melanoma. But there have been some major discoveries and major advances, at least in our knowledge of ocular melanoma or uveal melanoma. One is that some fantastic work looking at a molecular signature. So actually looking at a variety of a host of genes, and you can actually test that set of genes on the melanoma, on the primary melanoma, and be able to predict, for the most part, what your risk is. So is it a very low risk, I mean, is it unlikely to come back, or is it very highly likely to come back? And we now are anticipating and planning on using that information. We're actually doing that now, particularly over the last year, about how to follow patients. Ultimately, this is a knowledge, and the bottleneck, I'll talk about it again, is that where are the therapies coming to be able to exploit that? And about most recently, we've looked at other genes in ocular uveal melanoma. And GNAQ or GNA11 mutations have been identified in about 50% of these ocular melanomas. Now, that doesn't appear to be a gene that is targetable, so you can use a GNAQ inhibitor. It's not clear that that can be done, but it does appear to activate a pathway that you saw, I've shown you a few times, it's RAS, BRAF, MEK. That's what we're calling MAP kinase pathway. And so it does appear to activate that pathway, and so potentially is driving the growth of those cells. And so we are participating in a clinical trial, again, trying to exploit that with these MEK inhibitors. And again, if you recall, I actually have a little diagram on the bottom there. So MEK is one of those things on the pathway. Can you block that pathway and ultimately result in good responses and long-term control of the disease? So BRAF is the hot area, and what everyone wants to know about. So in 2002, they did a whole host of cell lines of different cancers, actually, but melanoma appeared to be the one that kind of jumped out. At the time, it looked like 2/3 of melanomas actually harbored a BRAF mutation. As we've looked at patient samples specifically, and started to do some trials, it turns out probably more along, for all patients, About 50% of melanoma is part of this mutation. But if you look at certain subtypes, actually the percentages change. So if you actually look at young people, so less than 30%, potentially 80, 85%, maybe more, that have mutations. This appears potentially more related, the more common type, I'd say, of melanoma, where these areas of high intermittent exposure. And so, and again, kind of tricky because it doesn't appear that UV can induce that mutation. But it appears this is not an inherited gene, this is an acquired gene. Why it happens, we don't know. It is, again, a fascinating story because it has been shown actually to be present, this mutation specifically, been present in normal melanocytes or normal nevi, or even a little bit of atypical nevi. This is difficult, technically it's very difficult. I'm trying to do some of that work again to try to exploit it for more early interventions as a preventive measure. But the fact that it occurs in some studies at a relatively high frequency, but this melanoma is still relatively rare, it does appear that it may be necessary but not sufficient. Again, this is the very beginning of the story. So it also appears to be very specific. Actually have one spot that is abnormal, and that is enough to cause this protein to continue to be produced and cause proliferation of cells. So this specific mutation, V600E, is over 90% of BRAF mutations. There are some other mutations, and like I mentioned with KIT, it may predict, we don't know this quite yet, it may predict your ability to respond to different therapies. So again, this is an activating mutation, so this kind of again drives the growth of the cells. So there's a few out there too, in particular, BRAF inhibitors. The biggest story has been with this PLX 4032. That second line there is basically other. If you see it anywhere, those are the same codes for that. Companies change, and they're had a trade name now, Melanoma. In phase 1 studies, this is phase 1, and like the first time you give it to people, it's a safety and dose finding study. It did appear to be very well tolerated and be able to even work on the formulation of the drug itself. These are pills. Be able to concentrate enough to be able to block BRAF, and ultimately with those optimization of those things, you can actually see response rates up to 80% of people with BRAF mutations. There's a phase 2, as reported at least at the meeting. More details will be presented this year at our national meeting. For those that have already been treated with something else, you still have a very good response and appears to have a good control of the disease for an extended period of time. About 50% of people respond. So there's another agent, this GSK, with a bunch of numbers there, XL281. Actually, the GSK agent, actually in preliminary studies, may even be a little bit more potent, but whether that translates into outcomes, we don't know. So there's a number of trials, well, a couple of trials we're participating in here, and hope to in the future as well. So we have the BRAF, for those that have a BRAF mutation, they'll be randomized to the agent versus chemotherapy, which nobody likes. We can certainly talk about that, some of the controversy over the last year. But this particular trial, if you don't respond to the chemotherapy, you do get your crossover. So everyone in the trial has an opportunity at least to get that agent. We also have a phase 2 trial with the same agent, specifically for patients with melanoma in the brain. And so this has been a real problem with melanoma controlling the brain, although certainly early signs are that if you respond to the agent, you're likely in the rest of your body, you're actually likely to respond in the brain as well. This is a trial testing, looking to see if that is indeed the case. And in the future, we're trying to do better, because ultimately, we think that these may grow, but doing combinations, like I showed you again, those pictorial, of different spots, ultimately to exploit what we know about resistance. So can't have pharmacology without some pictures. It's a PET scan, so most of those black spots are melanoma. With PLX 4032, you see them virtually disappear. The problem with this is very promising, but we do see over time most patients will have that grow back. It's not everybody, and they're still kind of following people. We are starting to learn about why this is the case. And hopefully, certainly we can control it for a while, and as our knowledge expands, we can kind of go around that. So it's still an opportunity to get additional agent, maybe even in combinations. And so combating this resistance, this is a huge area of research now. This is very exciting, these BRAF inhibitors, but again, why don't they work long-term, at least for the majority of patients? And so we know that they can develop or activation of these alternative pathways. Actually, some evidence that farther on down that pathway actually have more activation, so it goes around and that way goes right through. And we don't know this yet, but new mutations in BRAF, I put there outsmart, it's not really smart, it's just really wants to live, the cancer really wants to live. And unfortunately, hopefully, we can outsmart the melanoma in the future. So these targeted agents, we think, we're not sure if actually we are getting rid of the cancer altogether, right? Just like I mentioned, leukemia, this is picture Magic Johnson, who was diagnosed with HIV in 1991. 5 years before, it was a death sentence. Who knows how long he would have lived. But now he is, 20 years later, functioning, what we can all tell, a pretty normal life. And of course, he's having to take some of these treatments, and we don't know his personal life, but he certainly seems to have agents that are tolerable to a point where he can kind of live a normal life. This may be, again, if we don't get rid of the disease, it may be something, it's certainly a worthy goal to be able to take something, to be able to control that growth over a very long period of time, hopefully live a normal life. So my last few slides. So BRAF is exciting. Not everybody has a BRAF mutation, right? Not everybody has a KIT mutation. What do we do with everyone else? Or even in that, I mean, is there something else within patients who have BRAF mutations that we can also exploit? And so there's a few centers around the country that are working on this, and we are actually hoping to be a huge focus of our future care and cancer care here at the University of Michigan. So right now, you're diagnosed with melanoma, here are your options. We'll do it and see what happens. We hope that what we ultimately do, and actually we have now an open protocol to do that, where we can actually take the tumor and do an entire molecular profile of that tumor. So we can identify BRAF mutations or KIT mutations or a whole host of other things. Now this is very early on, and again, our knowledge probably we'd be able to detect it far exceeds what we can do. But we need to start working towards this. And so ultimately, you can have a molecular profile. You don't have melanoma or colon cancer, you have melanoma, and you have a number of these different abnormalities and aberrations in the tumor, and be able to design a therapy ultimately to be more personalized. Say, okay, you have this, we're going to do these things, and we can have, for the most part, be able to predict that, predict the benefit. So there's, again, a whole host of genes that we think may be informative or may be targetable. Again, there's a whole host of abnormalities that you can see that actually we're not sure do anything, and maybe these called passenger mutations. And so, again, we're trying to learn this. So the likelihood is that we're going to have, again, a slew of information, and we're going to work very, very hard to figure out what to do with that. And ultimately, the bottleneck is the treatment itself. So there are a few mutations that we have active treatments and treatments that have been more advanced, but we need to have more. So we also are developing and enlarging our phase 1 program, so patients of mine that we talk about that. There are pros and cons to that, but ultimately, those are new agents, and we have an opportunity to target, and with our knowledge of what's going on, be able to put you into a treatment that makes the most sense for you. And so again, we're putting a lot of effort and expensive resources into developing this. And so my last slide is that we're all in the melanoma research community, and certainly in the patient caregiver world, we want to do better. And so we have a number of trials here that we're continuing to hopefully have something for everyone. And if you don't have, and if that doesn't work out, then we have an opportunity to do something else. So patients of mine, hopefully you've heard me say that we want to have a plan, and we want to have options. And so clinical trials are a vital part of that. So these are new therapies, new hope. Of course, if you do whatever therapy, IL-2, if you live in that network, it doesn't matter. But we want to know where we're going, and again, we can't predict right now if you're going to benefit. And so having as many options as possible is critical.